Hello, everyone. Thank you so much for being here. My name is Jae-hyo Kim, and I teach the basic theory and technology of acupuncture at Kwang University. I also do research focused on acupuncture techniques using ultrasound imaging. Today, I want to cover three main things. First, how we can use ultrasound imaging in acupuncture. Second, understanding the risks that can be caused to patients during treatment. And third, how using this technology helps us confirm the accuracy of our treatments and increase their clinical validity. Professor Cheng Dan-an, a prominent 20th century Chinese acupuncturist, gave us a great way to think about acupuncture's effectiveness. He broke it down into three key factors: resonance, which is the doctor-patient relationship in acupuncture; engagement and concentration of the practitioner, which highlights their medical expertise; physical stimulation, which is the actual needle intervention technique. His view moves us past the abstract idea that acupuncture follows meridian theory and focuses on the physical reality of stimulus and response. Similarly, in his book, Evidence-Based Surface Anatomy for Acupuncture, Professor Huanglong Sheng, a leading acupuncturist of the 21st century, points out a historical paradox. He explains that ancient surface anatomy originated from the fundamental need to locate points for interventional treatments like acupuncture, and these empirical achievements eventually led to our acupuncture theory. However, despite thousands of years of clinical practice and a wealth of accumulated knowledge, a complete standardized surface anatomy is still not fully developed. He argues that in modern acupuncture medicine, acupoints are concepts that integrate our knowledge of surface anatomy and the body's pathophysiology for diagnosis and treatment. In the modern world, we often define acupuncture as simply inserting a filiform needle into specific points based on meridian and acupoint theories. But if you look at ancient and pre-modern times, it was much more complex. Acupuncturists developed treatment tools specifically suited to the patient's symptoms and conditions. It wasn't just about one type of needle. This practice led to the standardization of 9 representative needling tools in ancient texts. For example, arrowhead-shaped needles stimulated the skin and subcutaneous tissue for dermatological conditions. Blunt-tip needles were used to press the vessels, invigorating vital qi and excreting pathogens. Scalpel blade needles were used for cases requiring surgical treatment, like abscesses from wounds. Coarse needles were used to remove swelling and adhesion in cases like intra-articular swelling or muscle tendon adhesion conditions. The targets were specific, too. It wasn't just the tools that were specific. The anatomical target varied based on the disease diagnosis. It's not just about stimulating a general point. For instance, if you're treating static blood, clotting, you target peripheral blood vessels. For muscular pain, you stimulate muscles or fascia. In other cases, you might need to stimulate the bones and periosteum. This brings us to the core of my talk. We need ultrasound imaging of the gross anatomy for 2 reasons: to ensure the safety of our needle therapy and to ensure the accuracy of our procedure, which boosts treatment efficacy. Let's look at one example: finding C7 in the neck, GV14 region. To accurately locate acupuncture points in the neck and shoulder, like GV14, we absolutely need to identify the 7th cervical spinous process, or C7. Traditionally, we use palpation techniques based on C7's unique immobility during neck movement. Think about this standard maneuver. You find the most prominent spinous process at the border of the neck and back. If you find 2, you hold them with your index and middle fingers. You ask the patient to flex and extend their head. The key is that C7 doesn't move because it's strongly joined to the thoracic vertebrae. If the spine disappears when they tilt their head back, it's C6. If it stays put, it's C7, or T1. Researchers suggest this maneuver can identify C7 with about 77% accuracy. That's pretty good, but for safety and efficacy, 77% isn't 100%. Palpation alone makes it difficult to accurately assess every individual patient's physical condition. However, ultrasound imaging solves this problem by letting us accurately distinguish anatomical structures that palpation misses, such as using the transverse process morphology of the cervical vertebrae to confirm the vertebral level. Let's look at SI19. It's located near the shoulder joint, about 1 cun superior to the posterior end of the axillary fold. This area involves the latissimus dorsi, teres major, and deltoid muscles. Crucially, the thoracodorsal nerve passes right between them. If a patient has pain from that nerve being entrapped, our acupuncture goal at SI19 must be to relax the muscles and connective tissues compressing the nerve. The case report by Omadani is fascinating here. They performed ultrasound-guided hydrodissection to release the surrounding tissues entrapping the thoracodorsal nerve. I suggest we can apply a similar anatomical and therapeutic approach when needling SI19. For the posterior shoulder points like SI10, SI11, and TE14, their key characteristic is their close association with muscles and tendons that form the back of the shoulder joint. Specifically, we're talking about the infraspinatus, teres minor, and teres major muscles. We need to know where the nerves that supply those muscles are. Studies also show that trigger points in the infraspinatus muscle are highly prevalent right at the SI10 and SI11 regions. Let's look at another location, finding the lumbar vertebrae, low back. In the low back, identifying the iliac crest, the hip ridge, is critical for accurately inferring the level of the lumbar vertebrae. X-rays show the iliac crest is usually between the fourth lumbar spine, L4, or between L4 and L5. But if we rely only on palpation, we run into errors because the thickness of subcutaneous fat varies so much from person to person. Clinical studies show that while X-ray or ultrasound can find the hip ridge accurately, when doctors use palpation, the assumed position of the third lumbar vertebra often changes. To reduce the error when finding Jacobi's line, we should infer that the third lumbar vertebra, L3, corresponds to the spinous process when palpating the hip ridge.
Ultrasound imaging is essential here because it helps us determine the exact location of the iliac crest, regardless of the patient's individual condition, something that is difficult with palpation alone.
Professor Wang Zhang-Tao, a Chinese surgeon, has focused on perforating cutaneous vessels, large macroscopic units, also called angiosomes, as an anatomical feature of acupoints. He found that needling around these vessels in the Li3 and Li4 areas causes the clearest Deki sensation, suggesting this is an anatomical structure tied to the unique characteristics of acupoints. Using ultrasound imaging, he observed the needle stimulating these vessels. This allowed him to identify and explain the exact location of these classical acupoints. Furthermore, Doppler ultrasound showed that needling Li4 stimulates the neurovascular complex associated with the ulnar nerve. This is evidence that our traditional Deichi sensation is fundamentally tied to an anatomical structure we can see.
ST36 is another critically important point. Traditional palpation involves measuring 3 cun, or chon, below ST35, laterally on the tibia. But ancient texts also mention the arterial compression test at ST36, checking for pulse changes in the ankle area. If you press too deep, the anterior tibial pulse cannot be felt. This suggests the main blood supply around ST36 is the tibial artery, which runs between the fibula and tibia.
Modern research confirms this deep connection. A 2021 study by Liu et al. Found that electroacupuncture at ST36 triggers an anti-inflammatory response via the vagal adrenal axis. The neurons involved, labeled with PORKR2 Cre, are found deep in the limb tissues, not in the skin epidermis. Specifically, they are mainly observed in the deep layer of the tibia periosteum and the tibialis anterior muscle. When we use ultrasound around ST36, we can see the deep peroneal nerve running alongside the tibial artery, underneath the tibialis anterior and extensor digitorum longus muscles. These are the deep structures mentioned in the classical arterial compression test. In short, the evidence is strong. Acupuncture theory and practice are deeply linked to anatomical entities, and observing those entities with tools like ultrasound makes our treatment safer and more effective. Now, let's shift gears and talk about the risks and the therapeutic factors associated with needle stimulation.
The use of ultrasound imaging to observe the underlying anatomy is absolutely necessary for safe monitoring during treatment. Look at this image. This is a pneumothorax that occurred after a needling procedure near the GB21 acupoint. You can see the collapsed right upper lung. The patient felt extreme pain a few hours later and presented to the emergency department the next day. Here, the right lung is collapsed and the pleural space is filled with fluid, pleural effusion, due to pneumothorax and hemothorax. This is what we need to prevent. GB21 is critical for shoulder pathology, but it is unfortunately associated with adverse effects like pneumothorax. To prevent this, we must know the location of the lungs in this region. An ultrasound image of the GB21 area shows the trapezius and levator scapula muscles in the shallow layer, the first and second ribs deep to those, and then, right underneath, the lungs. Because of this anatomy, we created guidelines using ultrasound monitoring for safe needling. We even investigated how needling risk varies depending on the patient's posture and gender. The results show that the safe needle depth is highly dependent on posture and gender. Most importantly, these differences are highly dependent on the individual patient. This reinforces why individual observation, specifically with ultrasound, is necessary every time we treat GB21 to ensure safety.
Another potential side effect is fainting or vasovagal syncope. How is this triggered? The clue is in the Basold-Jarisch reflex. The accessory nerve, which controls the trapezius muscle, runs right through the GB21 area. Stimulating this nerve during acupuncture can increase its excitability. Ultrasound imaging of the GB21 region reveals the accessory nerve passing clearly between the trapezius muscle and the levator scapula muscle.
As you can see in this video clip, this is an example of acupuncture needling and pharmacopuncture being performed directly on the accessory nerve area between the trapezius muscle and the levator scapula muscle. Let's look at the abdomen. CV12 is a common acupoint for digestive symptoms like stomachache. Historically, many clinicians assumed needling here was a direct stimulation of the stomach in the abdominal cavity. However, recent research has shown a high risk of damaging visceral organs. In 62.7% of healthy subjects, the liver is observed right at the CV12 site on ultrasound imaging. This demonstrates that we must consider needling CV12 as a risk factor for damage to abdominal organs and prioritize treating the patient's individual digestive symptoms safely. Finally, for points located in the ilium and sacrum joint area, we absolutely need ultrasound for accurate needling. This region is complex, containing many muscles and tendons, like the erector spinae muscle, which makes simple palpation difficult for identifying the treatment target. BL25 is related to the tendons between the lumbar and hip bones. BL27 is a feature of the sacroiliac joint. Observing these anatomical structures with ultrasound imaging is the best way to improve needling accuracy in complex areas. In my teaching, I am prioritizing the use of ultrasound imaging when we cover meridian and acupoint theory and needling techniques. I believe we must combine anatomy and acupuncture, emphasizing that treating various conditions is an intervention with a crucial physical component. In conclusion, acupuncture is a therapeutic technique that involves the patient's response to the practitioner's stimulation. Ultrasound helps us safely and effectively bridge traditional practice with modern evidence-based anatomy, ensuring we hit the right target every single time.